Good morning. Not sure, Gerald, why you're the face that everybody's seeing right now, but that's awesome. They should see somebody's face, and I'm good with that. Hi, I'm Mark White at Idaho Estate Planning. We do estate planning. That's why we put it in our name. We also do some elder law, and our goal is to try to keep our clients safe and with a high quality of life, and to preserve their control over their lives as long as possible. And we've been doing a series talking to folks about planning. I didn't want to use the word planning, but we're going to use the word planning ahead, because there's some things coming down the road for most people. And the best way to make that work for you is to be ready and to be planning as we go down the road. So today I've got some experts with me. I've got Dr. Louise Helou of Brightview Health. Dr. Louise has been in the Valley here for a little over a year. Yep. I guess it's too long to say welcome, but glad to have you here. Gerald Bozen is the administrator at Life Care Centers of Treasure Valley, or at Treasure Valley?
Of Treasure Valley.
Of Treasure Valley. And Life Care Centers, it does rehab and skilled nursing. So today we're talking about, if you get to, and Dr. Louise, you can help me with this. Maybe it's not if you get to, but when you get to that point, you need a little bit more, we call it skilled. And what we mean by that is medically skilled, not that the home care people aren't skilled at what they're doing, but the shorthand that we use when we say skilled is talking about folks that have medical training and can provide the different medical services. So we're going to talk a little bit about that today. And the two sides are, can you get this at home? Can you prepare for this situation? And then we may have to transition into a skilled nursing community or facility. So let's get started. Dr. Louise, why don't you take a few minutes and kind of walk us through what you do, what brought you to the Boise area, and you know, so just a little bit about your business and about you. And then Gerald, you take a few minutes after that and help us to understand a little bit, you know, the business that you're in. Does that sound good?
Sounds good.
Let's go.
Hi, everybody. So I'm Dr. Louise Helou. I go by Dr. Yee. I am a family medicine / geriatrics medicine specialist. I went to USC for family medicine, and then I went to geriatrics fellowship to specialize in specifically geriatrics. A lot of people ask me, what does geriatrics mean? It just means that I focus on patients who have, you know, who are a little bit older, that are usually above 65, and patients who are just a little bit more complicated. I usually like to take them head on. So that being said, you know, my goal is for everybody to age gracefully. We have a private practice in Meridian, and I also go out to the fields on Tuesdays, which means I do home visits, I do facility work, and I see patients who are unable to come to the practice physically, so that I can at least give them medical access. I've been here a little bit over a year, and I, you know, chose Idaho, not knowing where Idaho was in the beginning. I chose Idaho because that's where a lot of more of the elderlies are moving towards, and I feel like there was a need for somebody that can help them as much as possible. So that's pretty much what brought me here. I love, you know, seeing my geriatrics patients, giving them the best quality of life as possible, getting them off of as many medications as possible, because unfortunately there's a lot of side effects for medications. So our goal in our practice is getting them off whatever we can, even, you know, if necessary, of course we keep them on it, but for the most part, if we know that we can get them off of the medication, we definitely do. We do specialize here differently, where I actually do a lot of holistic medicine. I do have an acupuncture background. I'm a licensed and certified acupuncturist. I went to acupuncture school before I went to medical school. And then I also do osteopathic manipulation as well. What does that mean? It just means that I do a lot of things hands-on. I use, you know, as much natural supplements, as much as I can do, just with everything that's as natural as possible. So that's pretty much my practice in a nutshell.
Very good. Thank you. I haven't been by yet for you to stick the pins in, needles.
You gotta
in
come
me.
after August, because at the end of August, we're gonna make a smaller renovation. So afterwards,
Ah.
come on by, and then we're gonna probably try to do a smaller grand opening. So we'll get you an invitation out there.
So this is off topic a little bit, but a lot of people don't understand acupuncture.
Uh-huh.
So for those of us that aren't as familiar with it, explain it just a little bit, and then why people would come and do that.
Sure. So what acupuncture is it balances out your body. We have a lot of times when I look at somebody, I take off my, you know, my Western hat, put it aside, and then I put my traditional Chinese medicine hat on. What I look at for a lot of patients is I look in their tongue, I feel their pulse, and it tells me a huge story about somebody. You know, people can say, oh, I have really bad heartburn. I've been on omeprazole. I've been on Zantac, Tums, and please do not be on Zantac anymore. It causes cancer. Anywho, and so they're saying, well, there's nothing else I can do. I've seen a GI specialist. I've done all these workup. So what ends up happening is I use acupuncture to help lower the acidity naturally. I help patients, you know, come off of different medication. I personally have Bell's palsy, which means that half of my face was completely paralyzed. It looked like as if I had a stroke. And this is, you know, happened to me when I was in 10th grade. And I got introduced to acupuncture, and I'm like, you want to do what to my face? And amazing, no medications, nothing. My face completely recovered. I have all symmetry, kind of, right? And so that really helped me figure out, wow, there's something else besides a Western medicine. So I've had helped patients with gallstones and not having them go get their gallbladders out. I've had helped them with diabetes, high blood pressure, arthritis, back pain, you know, pretty much you name it, I pretty much have helped. I don't say, you know, it will take away everything. I don't say that it's going to relieve you 100%. It won't take you back to baseline, but it can help. You know, I don't have the miracle wand that says I can take away dementia. I can't take away cancer or anything like that, but I have been able to lower a lot of the medications, especially with pain and blood pressure and diabetes, and naturally lower everything in their body. So acupuncture does a lot of balancing.
Excellent. Well, thank you.
Mm-hmm.
Gerald,
Yes.
that.
I don't think I can. My name is Gerald Bozen. I am the Executive Director of Life Care Center of Treasure Valley. I've been in skilled nursing for 20 years now. I grew up in Eastern Idaho and moved to Treasure Valley about 15 years ago, and loved it every minute of it. I'm glad to be from Pocatello.
Isn't that the joke? Far from?
Yeah. But anyway, I've been at Life Care Center for about 2.5 years. This is a large skilled facility in Boise area. And Life Care Centers are all over the country, but we have 7 facilities in Idaho, 2 in the Boise area. And skilled nursing, if you don't know what skilled nursing is, it's subacute care as well as custodial care. And what that is skilled nursing is it's a service that only medical trained professionals can provide, such as nurses, occupational and physical therapists, speech and audiology professionals. We also employ certified nursing assistants who provide the day-to-day care for, we call it activities of daily living, which that is all the things that you do that and on a daily basis that you may need help with, such as eating, toileting, transferring, turning, walking, all those things. We help assist people as they need them. In general, most people come here on a short-term basis where they come here for rehabilitation from being in the hospital. And they utilize their Medicare benefit. And our average length of stay right now for short-term is about 18 to 20 days.
So they come, say, typical from what I've seen is a fall.
Correct.
Go to the hospital. Hospital, you know, they might have to do surgery and put screws into a hip or, you know, into another bone. And then they need to rehab, which in my tiny brain means that they got to learn to walk again, or they've got to learn to walk better, or they got to kind of get back to whatever the baseline was. And so they will be moved from the hospital to rehab, which is you guys.
Correct.
And then the idea is that they don't stay in rehab forever.
Right. Our goal is to get them home, or at least to a lower level of care, including assisted living and independent living. But the goal is to get them home, or at least back to the level where they were before they went into the hospital.
Well, and from the outside, one of the reasons is that skilled nursing is not cheap. The rehab is not cheap. It costs some money.
Right.
And so if we can and we can get them back home, that's the goal for most people as well. But and so Dr. Louise, back into this a little bit. Home isn't always the best place for these people.
Right.
At least not without a little bit of help. And we were talking before we came on, what I tend to see in my practice is people's plan. This is their overall plan is to stay in their home. And often what they want is for the kids to step in and help them. And that's awesome. I get it, but kids aren't always trained to help them when they come home.
Right.
And so going home, unless there's a little bit more, is not always the best pick for them.
Right. So the most important, when they are ready to go home, one of the main things that most nursing home is great about is making sure they actually have a follow-up appointment with their primary care physicians. And this is important because, first of all, they're given the right medications in the nursing home. However, they go home and guess what? They have a bunch of home medications that they say, am I supposed to take the medication? So guess what? They're actually doubling the amount of medications.
Oh.
So it's extremely, extremely important to follow up with the primary care physician within the first week of going home in order to clean up the medication list. That's number one. Number two, if the patient is unable to get into a car and physically go to an office, the best thing to do is finding a physician that can come to your home. The great thing is Medicare is covering it. They're covering home visits, and if you have secondary, whether it's HMO or PPO or Medicaid, they cover the second portion of whatever Medicare doesn't cover. And so a lot of times it's not even anything out of pocket for a physician or a nurse practitioner to come into the home and to clean up, essentially. And a lot of times I love doing home visits, especially when a patient's debilitated, because I can physically see, what are they eating? Is there anything in a home that I need to worry about?
Yeah.
Like, for example, barriers. Are there rugs that may cause patients to trip over with a walker, right? And then is there a huge coffee table and the patient has to maneuver sideways to get to the couch? So if I'm actually able to go to their home, it allows me to visually see whether or not I can make some suggestions on some changing of configuration in the house, not just by cleaning up the medication, also saying, look, this can of soup has 2,000 milligrams of sodium. This is not good for your blood pressure or your heart failure, you know? So it allows me to really see them in their home and allow me to tell them, hey, how about we make some changes here and there? And the other thing is, once they get out of nursing home, you know, home health is also usually ordered. A lot of patients are freaked out. Oh my gosh, there's going to be somebody coming in. How much is going to cost me out of pocket? Majority of the time, I can say majority of time, Medicare and insurances cover home health. Home health includes physical therapy, occupational therapy, speech therapy, and even a nurse and a bath aid. And that's going to allow these patients to be able to stay in their house for a little bit longer, hopefully a lot longer, but a little bit longer, without going back, causing a bounce back into the hospital or a bounce back into a nursing home, because we don't want to keep seeing these patients in and out of the hospitals. That's the point of having the medical care team come into the home. It's to allow them to stay home and be comfortable and not wonder what's going on.
Okay, so you outline a number of things that people can bring into the home, or the help that they can bring into the home. We talked last week a little bit about home care, or the personal care services in the home. And the point was made, not everybody's comfortable with somebody in their home. And so they mentioned that, you know, if you're at home, they have to be there. You know, if we're at that situation where you need somebody 24/7, they'll be in there on their phone while you're watching TV. You know, they'll be sitting there while you eat. Maybe they'll be helping you to eat, but they're going to be there. And I don't know very many people that are ready for that. And so this is something to keep in mind.
Right. Agreed. But at the same time, when they first get discharged from the nursing home, it's extremely important to prevent them from having another episode of anything, whether it's heart failure or anything. It's, you know, if they keep the 24-hour caregiver just for a month or two, that's going to at least allow the patients to get back into the routine, even though they may be on the phone. Hopefully they're not, because they're on working hours. But if they are, you know, obviously talk to the bosses and making sure that they're really monitoring the patients, because the priority is the patients. It's not their phone, right? But it's also important to have these people help out, because a lot of times when they get back home, they're confused about what's going on. You know, they're confused about how do they make food, you know, and then because anytime as anybody returns home, it takes a whole week or 2 or 3 weeks or 4 weeks, whatever, to get back into the same routine. They may be more afraid to maneuver around the house because guess what? I fell in my house and I broke my hip.
Wow.
Oh my goodness. But allowing somebody to help out in the house, I think is extremely important to kind of, you know, guide them and allow them to get back into the routine. That's the most important. I'm not saying forever, but
yeah. But so the option then is, Gerald, they'll either stay with you a little bit longer, or they'll find a place in assisted living. So maybe it's worth having somebody there for a short period of time to prevent or delay the time that they're going to spend in a community like that. But can either of you give me an idea how those costs measure out? I mean, it's got to be expensive to have somebody in the home 24/7, even though, Gerald, if they're in rehab or if they're in skilled nursing, that's pretty spendy. But is having somebody in the home, somebody, you know, with skilled care, is that cheaper? Or is that about the cost the same? What do you got? That's an
Well,
unfair question.
that is an unfair question. Either way, it's very expensive. Now, with rehab, generally, we're talking about the population that has Medicare as a primary. And whether that's through an insurance company that's managing their Medicare or whether they have the traditional Medicare. When they come to rehab, those costs are generally covered at 100% for the first 20 days or so. You know, each plan is a little bit different, but in general, your rehab stay is going to be taken care of. If you have to stay a little bit longer, there may be a cost involved in that, but it's in your best interest to stay for your rehab as long as possible so that you're ready to go back home so that you can stay there as long as possible.
Got it. Yeah. No bounce backs here.
Right.
That works in the commercial world, but we don't want it here. We don't want to bounce back. Okay, so from your perspective, I'm old now. I'm in my 60s. What should I be thinking about? Are there some things that I should be thinking or doing or arranging now to maybe delay that trip to the hospital, which kind of starts this whole thing going?
I can talk from personal experience. My mother passed away last year, and we went through this as a family. And I think what you need to do is you need to talk to your support group, whether that's your kids, whether that's friends or whatever. And if you decide what you want, now you're not always going to get what you want, but you need to talk about it. Because if you want your kids to take care of you, that may be great, but they may not be able to. They may not have the skills needed. They may not be able, have the time. They got to work, they got to take care of it. And so all those things should be discussed ahead of time. What if this happens? What if that happens? And then understand your insurance. Know what's covered, know what's not covered, so that if something happens, you know, okay, I can go into the hospital, I can go to rehab for 20 days and I can get home, and that's not going to cost me because I have Medicare. But if you know, I get a degenerative disease and no one can take care of me, and got to go into skilled nursing, that costs, $10,000 plus a month. How am I going to pay for that? All those things should be discussed ahead of time.
And if it's your family, if that's your support group, they've got, and they're never on the same page, okay? Should we just say that? In general, yes, we understand we want to take care of mom, but everybody has their own opinion about how we're going to do this. And the daughter who lives in town, of course, she's the one that's going to provide the care, even though she might not be able to, as far as she's raising her own family and financially they can't afford to do that. But there are some assumptions. And so I particularly like that, Gerald, from the standpoint that we're having this discussion. We're going to understand this happened and we've already got a plan in place. There's that P word again. We've got a plan in place. And Dr. Louise, we can't always plan everything. There's stuff that happens, but we can at least have an outline and we can kind of know where we're going.
Correct.
Is there any more from the health side
Sure.
or the physical side?
One of the main things when I do any type of visits with my patients, one of the first questions I ask is, do you have your advanced directive planning done? Again, that's a P word. The advanced directive planning is extremely important because if, it includes who's going to take over financially, who's going to take over medically when you're incapacitated. What about what's going to happen if your body decides to give up? Do you want to be resuscitated? Those are all important questions to plan ahead, because you wouldn't want to put your kids or your loved ones in that position of second guessing and saying, oh my goodness, I don't know what she wants, but we're going to do this. So then it kind of goes against what the wishes of the patients are. So I feel like if it's extremely important for a physician, their primary care physician, to really know what their thoughts are, so that when the hospital calls me, I can say, oh yes, I have this on file. Mrs. or Mr. So-and-so would like this to be done, versus, oh, I don't know, I haven't even had a discussion with them. Do they want to be on hospice? I mean, that's a whole new conversation, right? So my goal in my practice is that we try to have almost everything ready in regards to the medical portion, but I always tell them, make sure you talk to a lawyer about the rest of it, whether it's, the healthcare directives or the POC season. Those have to be written out so that there's no questions asked. And I always give them my personal experience with my grandfather. He had everything ready. Thank goodness he had, things written, but guess what? He never went to a lawyer. So it didn't take effect because it was never notarized. It was all handwritten. So nothing happened essentially. So the families were completely drawn apart on my family side. And it was just really devastating to see how bad, everything worked out at the end. So I definitely, for me, because it touched me personally, I always try to tell my patients to make sure that you have everything planned out. Mm-hmm.
So you're not going to find this really interesting, but a lot of other people do. We've put together some fairly complex plans. We've put together some really intricate things. And the thing that takes the most time and the most explanation is the power of attorney for healthcare, the living will or advance directive, as we call it, and discussing that and understanding what people want. And then, yes, our job is to get that onto paper and get it executed properly. And so that's a long conversation. And then we turn around and our goal is to have a family meeting.
Correct.
Where we turn around and the parents to the kids or to their siblings or whoever's going to step in and have the conversation, and the conversation runs from, no, I want you to try to, preserve my life as long as possible, to the other end of the spectrum, which is, we had a good run. It's time to go. Just let me go,
Right.
Disconnect the machinery. If I'm in a persistent vegetative state, or if I'm terminal and the only thing that's keeping me alive is, artificial means, disconnect me, let me go. And in between that is disconnect me, but provide me food or hydration. So that's a huge conversation to have. And Gerald, you were spot on. And Dr. Louise, I've seen those situations where they didn't have the planning, and yeah, as you mentioned, families can end up on two sides of this thing. And I got a friend who was the healthcare power of attorney. Mom had determined that she wanted to be disconnected if she were in that situation. This lady's sister was out of the country and she couldn't get hold of her. So she went ahead, because it was that situation and something needed to be done. She exercised mom's wishes, which were to be disconnected. Her sister came home and called her a murderer.
Oh, no.
You murdered our mother. And the only thing I can say is, Mom, that's your responsibility. And you got to do it now rather than leave it to the kids, because kids are struggling anyway, and they don't need this. So
Mark,
go ahead, Gerald.
I was gonna say that is so true. I mean, just to give you an example, probably I would say 75% of the people that live in our facility never made a plan. they crashed, and then life took over where they were forced into things they didn't want to. Now, fortunately, we can provide good care for them, but it wasn't what they wanted or what they decided.
Yeah.
The decisions are taken out of your hand if you don't plan ahead.
So let's move from the legal paperwork stuff, and Dr. Louise, let's talk about from a health standpoint or from a physical standpoint. Is it inevitable? I'm gonna have a fall. I'm gonna have an event. I'm gonna be in the hospital. Is there anything I can do about that? Is there some planning or some effort I could do now to minimize that?
So the most important thing is, again, it's following with your primary care physician. You know, yes, there are people that are going to think, oh my gosh, I'm bothering my doctor too much. But I've always told my patient, it's better to bother us more than not, so that we can address it. Because if we don't know what's going on, we can't second guess that you're hurting somewhere. When you're in pain, you're going to compensate a certain way. And then at that same time, you're going to have a higher fall risk because you're not walking the way you're supposed to. So it's always better to keep your doctors in the loop of what's going on with your body, because, you know, we can at least see if we can address it. There may be times when we're going to say, you know what, it's nothing. And that's okay. You're not over asking us, because if something happens, at least we're kind of hyper aware of it and say, okay, you know what? X, Y, and Z happened last week. It makes sense why this is happening right now, right? So if there's pain, if there is dizziness, if the blood pressure is off the roof and because you skipped the medication, we still want to know. We want to know that, oh my gosh, you just had a heart attack. We know why, because you forgot to take your medication, versus, you know, oh, something happened, she went to the hospital, and oh my goodness, what do we do next, right? So yes, planning ahead is always the best thing, and keeping your doctor in a loop is always, always important, for sure.
So with your doc, you should go anyway, like your annual physical or wellness exam, run your blood, you know, tests, and look and see how everything's going. These are yardsticks, right? And tell us how we're doing.
Right.
And so we don't have to wait till we're hurting. But if we've had our annual maintenance and we have some problems, we should call again. We should touch base.
Please. I mean, we're here to help, right? Our priority is our patients. So whether it's something small, we can reassure, versus, oh no, come in now, versus nowadays we can even do telemedicine. So within, you know, between patients, within a 5-10 minutes, we can get on and visually see what's going on. That's going to help us a lot in determining what's the next step. Whether we have to order a bedside x-ray, whether I have to send one of my girls out there and grab some blood, whether it's a UTI that I can treat right then and there and not wait for it to become septic, right? Those are all big things for me to know. And the thing is, my girls know how to triage. My front office knows how to triage properly and understand when it's an urgent matter versus emergency, versus, hey, doctor will call you afterwards, you know? So they have been well versed in all the different scenarios. And so then it can guide them in saying, okay, well, you know, Miss So-and-so, if you can wait about an hour or so, you know, Dr. E will call you back, versus the girls are knocking on my door. Hey, doc, I have an emergency right now. What should we do next? Right? Because there's a lot of things that are uncertainty. We all are going one way no matter what. It's just a matter of when do we go that way. So let's go with grace. Let's go with beauty, right? So
we're talking about having the highest quality life that we can. We don't have to have a high quality life. I just kind of prefer it myself.
Right. And we want everybody to have that.
Yeah. Here's a follow-up question then. Gerald, you've seen this. Dr. Louise, I know you've seen this. If I happened to fall. So I was up hiking with my wife and my son and our dog, and I didn't make all the way up over a root on the trail. And then all of a sudden I'm tumbling and falling. Fortunately, because of an arthritic neck, I do my stretching every day, and we're walking the dog twice a day. I think I survived the fall better than if I hadn't been walking or I haven't been doing my stretches.
Correct.
Is this logical? Does this make
Very
sense?
logical. It's very
Okay.
logical. The more you move, the better it is, because the more you move, you don't cause yourself to have muscle atrophy, meaning muscle wasting. So the more you exercise, the more you move, just by walking 10 to 15 minutes a day is going to be sufficient for a majority of the population, you know, because you're allowing your muscles to keep building itself instead of wasting away. So yes, Mark, that's the best thing you can do for yourself.
So Gerald, do you see this if somebody has had a fall, if they are doing, as Dr. Louise mentions, that they've been atrophying, they haven't been walking or moving, does that make a difference for someone who's, you know, in pretty good health, but they've had a fall and they got hurt? Does this show up in the rehab?
Yes, it shows up every day. I mean, your potential to rehab and get home is much better if you have been more active. And what people don't realize is Medicare pays you to get back to where your prior level of function.
Yeah.
Now, if your prior level of function isn't very high, Medicare is not going to pay for very long.
Yeah.
So that's a big deal. I mean, if someone was walking around at home, driving, having a very active life, and they had to come into us, well, that's the level of care we're going to try to get them back to. But if they were sitting at home, sitting on their couch, maybe transferred into a wheelchair from bed or to the toilet or that's all we can help them get back to. So, yeah, it's in everyone's best interest to be as active as possible.
So Dr. Louise, add to that. So walking is good.
Walking, stretching is extremely important. Because a lot of times we're all kind of doing this, right? And so we forget to stretch every so often. That's going to be important. And then healthy diet. Healthy diet is going to be extremely important because why? Because if we're eating nothing but McDonald's, if we're eating nothing but Carl's Jr., our bones are never going to regenerate. We're not getting the nutrition that we need. We need the right vitamins to re-supplement in our body. When we're walking in this kind of heat, we tend to do a lot of sweating. So replacing electrolytes back into your body with Gatorade, Pedialyte even, or even just those little packets of electrolytes where you pour in the water and you're replenishing the sodium. Having a water bottle every single day, you know, next to you and drinking it, that's a key, because everyone's like, oh, I have one right next to me.
I have one, yeah, it's right here.
Right? But if we're able to drink at least 4 cups, not this whole thing, but if we can drink 4 cups of 8 ounces every single day, that's going to replenish us, because unfortunately, I see more than not, most of my geriatrics population being dehydrated. It hurts their kidneys. You know, I know they're afraid to use the restroom. I know they're afraid to do all of that, but it's extremely important to hydrate themselves.
I think that's one of the biggest issues we see is people don't want to drink water because then they have to go to the bathroom, and that's when they fall, and that's when they have issues.
Correct. I agree.
So visit with your doc, get a plan put together. We have the incredible advantage in the days that we live in to have medications that can make a huge difference in our lives. But they don't help if they sit up in the cupboard, in the bottle. We need to be taking those. That needs to be monitored. And then if we can supplement what the doctor's doing with exercise and diet, and you're not saying we have to go out and run marathons.
No. Just walking 10 to 15 minutes. moderate speed, meaning that I can hold a conversation. I can feel a little moisture on your forehead. That's all I care about. I don't want you to be huffing and puffing and look like you're about to croak or something. Just enough where you feel your heart rate going up just a little bit, okay? Because you want the heart to pump just a little bit so that it's really allowing all the muscle to flow, all the blood to flow in your body. That's important.
Well, it's not only good for your physical health, but also for brain health. We're talking, so Eric Collette, who does a lot of work with dementias, says we should quit talking about brain health. We should just talk about health. We should get the blood flowing, because whatever you do that's good for your heart is also good for your brain. So we worry so much about, well, what can I do for my brain?
Right.
Get out, exercise.
Right. I completely agree with that. Just the more you work out or exercise or just walking, we don't have to call it exercising. We don't have to call it diet. You just have to have a healthy lifestyle, right? That's
we won't call it a plan. There's not a plan. It's a regimen.
Right.
It's trying to come up with the word.
It should be part of the routine. It should be a daily routine that we should all take. Yeah.
All right, very good. What are some other things? I know there's the crisis, there's the crash, there's the event that happens. As kids working with parents, are there some other things that we should be watching for or sensitive to with mom or dad? Is there something that if we see something, we should maybe be talking a little bit more to them, or maybe visiting with their doc, or encouraging them to get to the doc? Or are there some other things that we should be worried about?
So the main things to kind of have red flags about is, once in a while, check in a medication cabinet. Hey, mom, how come there's so many medications left over? Or why are there so many medications, right? Hey, mom, how come, the house looks really unkempt and looks more like a hoarding? Those are all big signs, red flags. Mom says, oh, this hurts, that hurts. Did you fall? Maybe. Those are all red flags that the family should reach out to their primary care physician. Mom has been doing A, B, and C. Can you kind of see what's going on? Can you do some blood work? Can we get some x-rays? Can we see what else is going on with mom? So yes, if there's something small that changes over time, we need to know right away what kind of changes that we can address.
So with the medicine cabinet, we got a whole bunch of medicines, maybe with different doctors.
Huge thing. So like I always like to have my girls, my front office, contact the specialists that, the patients are linked to, so that we can see if there's any interactive medications, because sometimes patients think that, oh, this doctor's taking care of this medication. This doctor's I don't need to put them together. But in reality, guess what? They could be interacting, or they could be the same exact medications that they're taking.
Yeah.
And that can cause a lot of pitfalls. So if there's a bunch of doctors, hopefully a primary care physician has gotten a list of all the specialists there, right, so that we can all be in this, in one little communication group, so that we can ensure the safety of the patient, making sure all the medications work together. The other thing is also huge, supplements. If a patient is taking a lot of supplements, a primary care physician needs to know, because
what they are.
A supplement can cause significant changes to regular prescription medications as well, so that they can interact and cause side effects that we don't want.
Got it. And check if it's supposed to be done in 30 days and there's still a half a bottle and it was prescribed 6 months ago. That's an issue.
Huge issue. What's going on, right?
Yeah.
So why haven't this been done if it's already been like a whole month at that point?
Yeah. So Gerald, is that something, if they come to you, you got to understand all that stuff, right? You got to know what medications they're on or supposed to be on.
Absolutely. And that's the biggest challenge when we're sending people home. is making sure that if we don't feel comfortable that the person we're sending home understands what they're going to need to be taking and when they need to be taking, we need to make sure there's someone else involved that can help them with that, because like she said, they'll start double taking medications. They'll not take what they need, and they'll end right back in the hospital or worse.
Yeah, how often, Dr. Louise, is it maybe medications that play a part in falling because they haven't taken it properly?
Quite a high percentage, because there's multiple different reasoning behind falling. Hypotensive, right? Meaning that the blood pressure dropped too much. Hypoglycemia, meaning that their sugar's too low. You know, just specific narcotics, Xanax, Ativan, benzodiazepine. There are literally like a huge list of something called Bear's criteria, which is extremely important. BEER, yes, not the beer that we drink, but Bear, because Bear's criteria, it was named after the gentleman who discovered that there's quite a bit of medications that are black box warning for geriatric population that I like to review with, you know, my patients and saying, hey, what are these for? So there's a huge list of medications that can be high fall risk. Even just gabapentin that people have neuropathy for. So those are all high on my list.
And we control all those here,
Right.
but we don't control them once they leave here.
So it would be helpful for them to discuss all this with their kids.
Very much so.
Or somebody maybe that visits them on a regular basis so that they can pay attention.
Correct.
Now, there's probably some other red flags. I don't pretend to know them all, but these are things that kids who visit on a regular basis, they could notice the speech is slurred a little bit, or maybe they're favoring one side or another. And these are all red flags.
Huge red flag, possible stroke.
So I have to tell you this story. My daughter just graduated from optometry school.
Woohoo!
And an older gentleman came in, and as she was doing kind of the introductory, asking him questions and stuff, she was looking at him, and he had a problem with one of his eyes. And so she asked a little bit, just got a little bit of information. She turned to his wife and said, "You are headed right now to the emergency room. You need to go right now. Our exam is finished. You're going to go down and get in your car, and you're going to drive straight to the emergency room." She knew enough to know that high likelihood that he'd had a stroke sometime the day before, based on what she saw and what he said. Got him to the hospital, probably saved his life. Kids can do that all the time if they'll pay attention. And I guess here's the second part. And again, this is me not knowing enough about this, but we kids tend to be in denial, maybe as much as our parents, maybe more.
Right.
We don't want to see that. Oh no, her forgetfulness, that's just normal aging, you know, this, that, or the other. And so maybe it takes a little bit of backbone and courage to see some of this. Does that make any sense?
Yes. Oh, yes.
This is my conclusion, not other people's, but from what I've seen, it takes a little bit of effort and courage to step in and go, that's not right. There's something wrong here.
So memory loss is not a normal progression of aging. Memory loss, depending on the severity. Yes, of course, if we're tired, stressed, you know, we may forget one or two things. But having it progressively there is not a normal progression of aging. So there's a lot of misnomer about that one, because, you know, unfortunately, with a lot of physicians and nurse practitioners out there, I don't know what else to do, right? So then all they say is, this is normal. It's not. You know, it's let's try to fix something before it gets worse. Once they get to that other point of no return, then it's like, oh no, right? So it's better to accept what's going on and address it as soon as possible than not.
Very good. Very good.
One other thing I would like to just kind of add is, be careful that when parents are together, if one's needing more care, it's not always best to have the spouse be the one that's caring for them.
Oh, yeah.
I've seen so many times where, a spouse in good health takes care of someone that has chronic issues, and then they pass away
Yeah.
quick.
Earlier, right?
Yeah, the statistics are pretty brutal on that one, from what I understand. The caregiver spouse, that's just so difficult for them. Hey, one thing that I was reminded by my paralegal yesterday, she wanted me to have people understand that if, Dr. Louise, they don't have their healthcare power of attorney, they don't have a living will put together, and they're in the hospital at this point, we can't get in. We can't get it done now if they're in the hospital. That just right now, that is
Right.
extremely difficult. Gerald, I don't know about getting into your facility. It's difficult. If it's doable at all, it's got to be difficult.
As important as you are, I don't think you would be considered a necessary service.
Yeah, I get that. So following up on your advice, people should have these in place, and they should do that sooner rather than later. Dr. Louise, we got about 5 minutes left. Can you take a couple of minutes and talk about the post, the physician's order or scope of treatment?
Yes. So the post is extremely important. Like I said, please bring it up with your physician, even if they don't bring it up. It's extremely important because, one, if the heart stops, what does your mom and your dad want to have done, or your loved one, what do they want to have done? If your lungs stop, if you can't breathe, what do they want to have it done? Meaning that, do they want an intubation? Do they want, just a breathing CPAP, BiPAP, or just to allow their body to go naturally? Do they want, compression or shocking back into life? Those are all important. Other things that are important are whether or not the patient wants a G-tube. A G-tube is a feeding tube. Essentially, what it's saying is, I cannot eat anymore. Do they want to have surgery and have a tube put into your intestine to feed them and to keep them alive? IV fluid is extremely important. If they're really, majority of the time they go to the hospital, they're going to be dehydrated. Do they want the IV fluids? So these are all important discussions to have with the physician to be able to understand, what does your loved one want to be done?
So the post is a great part of the overall P word. What did we come up with instead of the P word? The
Routine.
Arrangements. We'll call it pre-arrangements, but I believe that's the funeral home business. Come up with
Let's not get there.
some other term for that. Well, thank you both for being with us today. I appreciate that. I know that there are people that are getting information, and we're going to have this recorded. You guys will have it up on your websites. We'll have it up on ours. So I know we didn't cover everything. And that wasn't the goal today because we didn't have time to do that. But man, if people can listen in on this and get started, Dr. Louise, how can they get hold of you if they have more questions?
So if they have any questions, our phone number is 208-509-8987. We also have a website, Brightview ID, BRIGHTVIEW as in Idaho.com. We're more than happy to answer questions and just help guide you guys. Even if you have questions, simple questions about what is a geriatrician, call us and just ask. We are more than happy to be a consultant as well and work with your primary care physicians to better the health of your loved ones. Gerald, how do we get hold of you?
Well, our phone number is 208-377-1900. Our website is Life Care Centers of America, and look up Life Care of Treasure Valley if you want to contact us that way. Give us a call if you have any questions on skilled nursing, assisted living. If we can't help you, we will find someone that can. We can tell you about what it's going to cost or what it's, so that you can have those plans. And we can talk to you about your insurance. We can help you find out how to know what your insurance actually covers. And that's a big thing that we can help with.
Yeah, Dr. Louise was talking about that before we got on, that you don't be afraid. Find out what the insurance covers. Get on the phone. Kids, if mom won't do it, get on the phone. And I'm very fortunate. I have two sisters that are they're closer to mom, and it's like, we're going to find out. We're going to do that right now. Let's find out. So yes, do that. Thank you very much for joining us. Hopefully at some time we'll break away and maybe go do some sushi or some
Yes.
Mexican again. That
Woohoo.
would be great. All right. Thank you all for joining us today. Take care. I hope that this helps you to, serve your people, the people that you feel responsible for and taking care of. So take care. Bye-bye.
Thank you.
Bye. We'll see you.